Hello, my name is Julia Sharif, and I'm an assistant professor at the Medical College of Wisconsin in the Division of Endocrinology and Molecular Medicine. Today, we're going to be talking a little bit about osteoporosis. So, some of our objectives include reviewing screening for osteoporosis, as well as the diagnostic criteria for osteoporosis. We'll also elaborate on treatment options, as well as discussing monitoring of patients on treatment. So, osteoporosis definition in its basic sense is a decrease in bone density, which leads to weak and brittle bones that are prone to fracturing. Here is some important bone physiology to know. Osteoblasts, these are cells involved in bone formation. They provide minerals and organic bone matrix to help form the bone itself. So they secrete these minerals and organic matrix called osteoid. Osteoclasts, these are cells involved in bone resorption, which is a process of bone breakdown. These cells secrete different enzymes that actually break down the material that was laid down by the osteoblast, such as mineral and protein, and they work closely together with those osteoblasts in a process called bone remodeling. This is a vital process that is very important for bone physiology. How do we diagnose osteoporosis? So this can be done via a DEXA scan or a dual X-ray bone densitometry. This quantifies the thickness or density of the bones using two different types of X-rays that hit different types of tissue with various absorption, like muscle, fat, and bone. Then this scan quantifies what's called a T-score. The T-score is a comparison of the bone density to that of a young adult population, and this is used in postmenopausal women and men over the age of 50. A Z-score is another thing you might see on your bone density scan, and this is a comparison between the bone density up to that of age-matched controls, and this is used in premenopausal women or men under the age of 50. So it's an important distinction to make of which T-score, which T or Z-score you are using to make the diagnosis of osteoporosis. The T-score is an important marker for postmenopausal women and men over the age of 50, and the cutoff for T-score is minus 2.5. Cutoff for Z-score is minus 2, and we'll talk about that a little bit later. So as I discussed, the T-score is minus 2.5 in postmenopausal women in order to make the diagnosis of osteoporosis or men over the age of 50. In premenopausal women and men under the age of 50, it's considered low bone density for age. So not technically osteoporosis, although you can make that diagnosis based on other criteria. And the cutoff is less than minus 2 for that Z-score, as I mentioned earlier. So those are particular cutoffs that you should be mindful of. Also, you can consider osteoporosis in a patient with a normal bone density or somebody with osteopenia, which is between kind of normal bone and osteoporosis, is how we kind of make that distinction with a low trauma fracture. So those are other things to be thinking about when you're making that diagnosis. So FRAX is another tool that we use in the diagnosis of osteoporosis as well as deciding on treatment. So FRAX is a fracture risk assessment tool, and this can be used to calculate a person's risk of fracture over the next 10 years. This tool takes into consideration non-modifiable risk factors like age, height, weight, as well as other osteoporosis risk factors like steroid use, prior parental hip fracture, etc. And when you make this calculation, if you get a hip fracture risk that is greater than or equal to 3% or a major osteoporotic fracture risk greater than or equal to 20%, this is considered high risk. And you'll see that in your calculation if you do it yourself. These patients who are at high risk of fracture should be considered for treatment, even if they don't meet criteria for osteoporosis based on that DEXA scan. So this is what FRAX looks like. You can actually just Google it and it'll pull up and you can actually do calculations for your patients yourself if you'd like. So who should be screened? So this is a little bit controversial based on what guidelines you're going off of, but overall, women over the age of 65 or 65 and older should be screened for osteoporosis. Men over the age of 70, this is a little bit controversial because in some guidelines, they don't really specify a threshold for screening for men, but it is recommended in some of the endocrinological guidelines to consider men 70 or older, or as I'll see in the next point, women under 65 or men under 70 with other risk factors, including steroid use, use of aromatase inhibitors, rheumatoid arthritis, etc. And anyone with a low trauma fracture should be considered for a bone density depending on the bone that is broken. So smaller bones, fingers, toes, stuff like that, we don't technically consider as an osteoporotic fracture. Skull fractures. Ribs is a little controversial as well, but typically it's not considered an osteoporotic fracture. So osteoporotic fractures, we're talking about larger weight-bearing bones like the femur, the vertebrae, the pelvis, things like that. And then here are just some links as well to some of the guidelines that I took a look at as well. I wanted to include those for you to take a look at too. So what are some causes of osteoporosis and bone loss? So there's several, actually beyond several causes of this. These are just some of the big ones that we talk about. So postmenopause, that is the big one that we think about. That's why osteoporosis is more common in women. After menopause, we see a drop in estrogen, and this leads to bone loss. So postmenopause is a big risk factor, which is not something we can avoid. Aging in general, for men and for women, can lead to outpacing of bone resorption to bone formation, so you'll have a net bone loss. Medications such as steroids, aromatase inhibitors, proton pump inhibitors, which are really common. You'll see a lot of your patients on these for prolonged periods. Androgen deprivation therapy, often in the setting of prostate cancer. Even Depo-Provera, the birth control injectable, can lead to some bone loss and delay that peak bone mass. So that's something to think about as well. And then other types of diseases that can cause osteoporosis, some secondary causes, thyroid and parathyroid disease. You can see it in chronic kidney disease, GI disorders, anorexia, neuromuscular diseases where patients may not be able to have weight bearing and things like that. So there's lots and lots of secondary causes of osteoporosis. There's a little link, a citation to an article about secondary causes of bone loss as well, and the list goes on and on. So it's a very high risk in some of these conditions. So, what do we do to help our patients get enough building blocks for their bones, such as calcium and vitamin D? So, calcium and vitamin D, again, are very important. Our goal calcium for patients with osteoporosis is around 1,200 milligrams per day, and that may vary based on the patient's other medical conditions. Patients with kidney disease, you do have to be careful about how much calcium you are using, especially in those on end-stage kidney disease or CKD 4 or 5, because that can put them at increased risk of vascular calcification. So, you may want to lower your goal potentially or speak with their nephrologist if there's a particular calcium goal you're aiming for. On the flip side, patients who've had bariatric surgery, GI disorders where they have malabsorption, they may benefit from higher dosing of calcium. Calcium, you can get it from food. Things like milk, cheese, yogurt are our highest sources. Tofu, nuts, things like that also have calcium. Or supplements. Supplements can be utilized as well, especially for our patients who struggle to get enough calcium in their diet. Perhaps they have lactose intolerance or have more of a limited diet that way. So supplements can be helpful for those patients. And then vitamin D supplementation amount does vary in terms of what people need. It depends on what the person's levels are. It can depend on sun exposure, can depend on absorption of vitamin D in their body. So there isn't a set recommended amount of vitamin D that we should be giving to our patients, although the standard amount in many multivitamins is around 800 to 1,000 IU. So it's important to monitor vitamin D levels at a baseline to see if your patient needs more vitamin D, typically aiming for a goal of 30 to 50 as our target. Exercise is very important as well. So weight-bearing exercise is what's emphasized the most. And I tell patients this could be any exercise where you're bearing your own body weight. And that could be running, walking, biking, anything like that. There's been some studies on Tai Chi as well. And ideally, incorporating a little bit more resistance will help overall with your muscle and bone strength. So, if you can even do a little bit of light hand weights when you're walking or some resistance bands, that can be helpful to help strengthen the bones as well. And there have been some trials out of different organizations that have looked at strength training as well and how that can improve bone density. So, there's a little article there as well. So pharmacologic treatment for osteoporosis is extensive. We actually have several different options. I'll kind of focus on the first one the most because that's the one that people see the most, but I will touch on some of these other therapies as well because it might be something that your patients may be on in the future. So let's start with the bisphosphonate class. This is a very common class of medication. It's most commonly used. And these medications have a strong affinity to bone and they interfere with osteoclast differentiation. So the osteoclast we talked about earlier in the slide presentation, they are those cells that break down bone. And so if we slow down those osteoclasts, prevent them from differentiating fully, this may help us preserve bone in the long run. So some of these options include alendronate, abandronate, risedronate, and zoledronic acid. Those are the main ones that we see in practice. And so we'll talk a little bit about each one of those in a little bit more detail. So first we'll start with the oral bisphosphonates. So alendronate is the one you probably will see the most. The brand name is Fosamax. It is a once weekly pill taken for roughly 5 years. Now, you can treat a little longer than this, a little bit shorter than this. Generally recommended not to treat beyond 10 years maximum, but usually around the 5 to 7 year mark, depending on the patient risk, is what's typical. The cons of this medication, the cons I've written in red, it can make acid reflux worse. So your patients who have had pretty bad acid reflux, who have had esophageal strictures, who have Barrett's esophagus, this is not really recommended for those patients because it can make it worse. One of the rare side effects that can occur that will come up quite a bit with a lot of these medications is something called osteonecrosis of the jaw, or ONJ. ONJ is a very rare side effect that can happen when a patient gets a tooth pulled, an implant, or bone graft while they're on the drug. And basically what it is it's a wound in the jaw that doesn't heal properly and can sometimes lead to these open wounds, infections, things like that. But again, it's incredibly rare, but it's important to counsel your patients on proper dental care and make sure you're aware of any upcoming dental procedures prior to starting them on bone health medications. Atypical femoral fracture is another rare side effect that can happen. Usually this happens when people are on the drug too long, so beyond that recommended duration of treatment. Atypical femoral fracture is a transverse fracture in the femur bone, and it can be devastating. So it's important to make sure your patients are aware of this. If they have any new onset hip or thigh pain, it might be important to image the femur just to make sure that there's no fractures brewing that you need to be aware of. But again, a very rare occurrence. And hypocalcemia, this is usually not severe hypocalcemia, but it is one of those drugs that can lower your calcium. So that's why it's all the more important to make sure your patients are getting adequate calcium intake while they're on bone health medications and in general, especially with osteoporosis. And some of the pros, it's oral. So a lot of patients like that. They feel a little bit more in control of the medication when they take it. And it might be easier to coordinate. It's generic. You can send it to the pharmacy. It's often covered. So that's a benefit to that. Abandonate, brand name is Boniva. This can be in an injectable form or an oral form, so it has a little bit of variety there. Usually treatment length is 3 to 5 years in duration in general, and sometimes can be a little more, a little less. Again, the oral version can make reflux worse, so something to keep in mind. ONJ and AFF are rare occurrences that can happen. Hypocalcemia, as with all of these drugs, and it doesn't have as good of a hip fracture risk reduction or non-vertebral fracture risk reduction. So it's not my favorite go-to for patients because it doesn't have as much of that benefit. One of the pros with this, it has a variety of preparations. So if a patient wants an oral drug versus an injectable drug, so there's a little bit of flexibility with the type of preparation you can use with Boniva. Risedronate, brand name is Actonel. This is a monthly or a weekly tablet, so there's a couple options there. Usually, again, for about 5 years, give or take. Similar cons to the alendronate. May make reflux worse. ONJ-AFF are a rare occurrence, hypocalcemia. And I guess the benefit can be less frequent dosing. So if you have a patient who says, I really don't like to take this once a week, it's hard for me to take this and keep it, waiting a half hour before I eat. So maybe less frequent dosing might be more doable for some patients. Other bisphosphonates, this is the most common one that I use in my practice. This is zoledronic acid, which is reclassed or Zometa. This is a once annual infusion given for about 3 to 5 years. And a lot of patients like this because it's once a year. Main side effects can be general body ache, something called an infusion reaction, where they feel flu-like symptoms for a couple days after their first dose. It's pretty common. About 1 in 3 patients will experience this. So it's important to educate your patients, tell them to be aware of this, and not to plan anything really big right the day after their infusion, just in case they have this side effect, because it does happen pretty often. They probably won't feel super great a couple days after taking the drug. The benefit is, as time goes on with subsequent infusions, that risk of having an infusion reaction goes down. Acute kidney injury, this can happen more so with reclass and Zometa than the oral bisphosphonates. This is something to make your patients aware of. And for all of these bisphosphonates, there is an EGFR or creatinine clearance threshold of around 35. So you have to be pretty careful with patients who have CKD to avoid using them depending on what their creatinine clearance is. So being aware of that. Hydration is helpful in patients who have a little bit borderline kidney function. You want to make sure they're hydrating and that you're repeating their labs after they start their infusion. ONJ and AFF, as well as those other bisphosphonates, and hypocalcemia, sometimes a little bit more so because it's an IV medication. There is no issues with absorption due to IV, so that's a pro. So in case somebody's not absorbing the oral medication, this would eliminate that issue. And it's convenient for patients other than having to go in once a year. They don't really have to think about it. They don't have to think about taking another medication. So a lot of people like that because of that aspect. So those are some of the pros. Now, some of these other drugs that we're going to talk about aren't as commonly used in primary care. They can be, but some of these more anabolic drugs are more so done through endocrinology, rheumatology, and orthopedics. So denosumab, this is another kind of anti-resorptive type of drug like the bisphosphonates, but it has a different mechanism than these bisphosphonate drugs. So this medication actually inhibits binding of something called rank to rank ligand. So rank is on osteoclasts, molecule on osteoclasts, and it binds to rank ligand, which is made by osteoblasts. And this actually initiates that differentiation of osteoclasts, this binding. And denosumab actually prevents that binding, prevents that osteoclast differentiation. The brand names are Prolia or Xgeva, and dosing is once every 6 months for up to 10 years. And I put some asterisks there because we'll kind of get into it. The duration is a little bit more complicated than that. So some of the cons. So one of the big cons is something called a rebound effect. And this is something that can happen when you come off the drug abruptly and don't transition to a bisphosphonate after the denosumab. And this is important. You always want to follow denosumab with a bisphosphonate at the tail end. This will help prevent that rebound effect or that rapid bone turnover that happens when you stop denosumab abruptly. When you stop it abruptly, that rapid turnover can lead to fractures, specifically vertebral fractures. Patients are very high risk if they stop it abruptly. So that's kind of a con with this drug. When you start it, you want to make sure you have an exit strategy. Am I going to be treating for a couple years and then go to bisphosphonate, or am I going to be treating for prolonged periods? And with prolonged periods, the longer you use it, unfortunately, the more difficult it is to stop. So oftentimes when I tell patients we're going to be doing it for more than a couple years, it's a lifelong use. So select your patients carefully if you do end up ever using this drug, and make sure that your patients are aware of your exit strategy. Infection can occur with Prolia, especially in patients on steroids and Prolia or denosumab at the same time. And then hypocalcemia is a little bit more profound with denosumab, so it's important to make sure, again, that patients are on adequate calcium. And then ONJ and AFF, as with the bisphosphonates, can occur. Benefits, though, it's a potent anti-resorber, so it really helps prevent that resorption process from happening. So it's effective, and you might see a little bit more bone density increase than just bisphosphonates alone. So it is beneficial that way. Romosozumab, again, now we're getting in a little bit to more of these complex medications that are used more frequently in subspecialty offices, but we'll touch on some of these. So this is a sclerostin inhibitor, and sclerostin actually inhibits osteoblasts, so those bone formers. So if you inhibit the inhibitor, you will allow osteoblasts to form bone. And this medication's brand name is Evenity. It's dosed once monthly for 12 months. And main side effects can be muscle or joint aches, headaches, muscle cramping. You can also get ONJ and AFF rarely with this, and hypocalcemia. And what's interesting about romosozumab is in some studies there was a slightly higher cardiovascular risk. So it's important to be aware of your patient's history of heart attack or stroke, because that may not be the drug for them. It's not recommended in patients who've had a heart attack or stroke specifically in the last year. This drug has the most bone building benefit, and it's once monthly dosing. For a lot of patients, this might be relatively convenient, especially for the amount of bone building that you get. And as I mentioned with the denosumab, all these medications should be followed by a bisphosphonate to help preserve the bone that you gained at the end of that 12 months. However, you don't get necessarily a rapid rebound effect with romosozumab. Teriparatide and abaloparatide, this is a PTH analog medication. This is administered on a daily basis. And when this is happening, when you have a pulsatile administration like this can actually lead to bone building, this PTH analog, whereas regular parathyroid hormone can lead to some bone loss. The brand name is Forteo or Tymlos. And again, it's a daily injection done for 18 months to 2 years. Main side effects can be muscle aches, dizziness, injection site reaction, and then it can increase your risk of kidney stones and gout, especially patients who are predisposed. And in rat studies, there's a higher risk of osteosarcoma that hasn't been directly replicated in humans, but we don't recommend it in people who've had osteosarcoma or radiation treatment to the bone. It is an effective bone builder. Patients can do it on their own. This allows them for a little bit of freedom with their time. They don't have to come into the office. And there's really no major risk of ONJ or AFF with this drug, which a lot of people like. Although, again, at the tail end of this medicine, you do have to use a bisphosphonate to preserve that bone that you've gained. So, again, you still will have that exposure to that drug. Raloxifene, this is a selective estrogen receptor modulator, or SERM. It actually acts as an estrogen agonist at the bone, meaning it's beneficial at the bone, and an antagonist at the breast, which is protective at the breast. It slows down bone resorption, and its brand name is Evista, and it's an oral medication daily. It can cause hot flashes, blood clots, and then stroke risk does go up with age. And it's not as effective as some prior options, but it is out there for patients who are intolerant to some of our other options. There is no major risk of ONJ and AFF as a main side effect, and it is protective against breast cancer. So family history of breast cancer, some of your patients, or personal history potentially, this might be a good option as well, but something to consider for your patients who are maybe intolerant to bisphosphonates or some of the other drugs as well. Hormone replacement therapy, so estrogen, and then coupled with progesterone if the patient has a uterus. This also slows down bone turnover, the resorption process. This can be dosed transdermally with a patch once or twice weekly or a daily tablet. The risks with this, blood clot, stroke, breast cancer risk, and those risks tend to increase with age, as with the raloxifene. So we advise not to use it in the patients over the age of 60 or patients who are 10 years post-menopause. And there's no risk of, major risk of ONJ, AFF, again with these, and it may also help with postmenopausal symptoms. Now, going through these therapies, they're all pretty much FDA approved in women. There's just in men, obviously, you don't typically use hormone replacement therapy or raloxifene, and romosozumab is not FDA approved in men. So, something to keep in mind when you're choosing therapies. This is kind of a little bit of a busy chart, but this has a little bit of some of these processes that we went through in terms of determining treatment. So it talks about bisphosphonates, denosumab, and teriparatide. The romosozumab is not on this, but this is kind of the osteoporosis guideline, the pharmacologic management of osteoporosis that is through the Endocrine Society. So this is something that is available to you online. I think I may have included the link as well in one of the prior slides too. So monitoring, ideally, it would be best to obtain a DEXA a year after the start of therapy or prior to switching therapies. However, insurance, especially Medicare, may not cover it unless it's been 2 years. So it's important for patients to check with insurance. And again, if there's a big issue with getting it annually, 2 years might be your best bet with coverage. And then when to stop these drugs. We gave some durations with some of these drugs, but it is important to initiate that drug holiday. All these medications, for the most part, aren't meant to be lifelong, unless you're talking about lifelong denosumab treatment. Sometimes raloxifene, you may have to treat for longer, but most of these drugs, you do want to initiate a drug holiday, and that's usually initiated when the patients meet a goal of a T-score greater than -2.5 or they have reached the end of max therapy duration and it may not be safe to continue beyond that time. So it's important to give patients breaks from these medications to minimize side effects, and they may not have benefit beyond that -2.5, greater than -2.5 threshold if they've already been on it for a decent amount of time. So things to consider with your patients when determining duration of therapy. So thank you all for your time. And my email was provided at the beginning of this slide deck if you have further questions related to these presentations. Thank you.